That's 64, 68. It wasn't stable initially. So anything that's over around 65 to 70 is considered stable. So just it's very difficult to get these little pegs in between the teeth. And if they're not flush with the implant, then open, then you'll get a false reading. So that tells me that this implant is quite stable. The beauty of the Osteotel is that it gives you a numerical reading, and I know I'm starting already at 64 to 68 ICQ reading, which tells me that I'm already almost at the stability level. Anything over 65 is considered osseointegrated. So this thing is not osseointegrated right now. This implant is mechanically stable to the point of almost being osseointegrated. And what I'm going to be doing is I'm going to be measuring the ICQ reading at subsequent stages during the healing process. And when I get over 75 or 70 to 75, I know that this thing is integrated and I can actually go ahead and put on my permanent restoration. So we're going to make the temporary now. And we have just a clear shell. And this is of the tooth before it fell apart. And this will just slip over his teeth, open. And what we're going to do is fill up the shell with acrylic, and we'll make him a temporary. The acrylic will fuse to the white piece, and we just hold it in his mouth for a few minutes till it gelates. Once it gets hard, we'll then take it out, we'll put it in some hot water, let it cure, then we trim it, and we make him the temporary. To make it easier, I took some acrylic, and we're actually using snap acrylic. You can use anything you want, but I find that the methyl methacrylate, which we don't normally use for crown and bridge anymore, but for this we're using it because it sticks to that white piece better. The newer temporary acrylic materials that come in the guns, they don't seem to adhere to this white piece as well. And what Tahiri did is she painted very carefully some Vaseline on the teeth without getting it on the white piece. And now we're just going to slip this right on top. And I just take my fingers and I just mold it. And all you really want to do is make sure that the acrylic doesn't get too hard that it's going to get caught into the embrasures and into the undercuts. So you've got to keep your eye on this and just have it close. Just have the patient close like that. And then what I do is I take the residue that's in here and I just feel for it when it starts to get a little warm. And you ask the patient when they start to feel it getting a little warm, close. And then we'll take it out. Once we take it out, we'll just put it into some hot water, let it cure, I'll polish it, and we'll put it in. The patient goes home with a temporary tooth, which is a great service. Because really, implant dentistry today is obviously still about rehabilitation. It's root replacement. We have the ability now to give a patient a third tooth option. They were born with their baby tooth. The baby tooth got replaced by their adult tooth. And for whatever reason, if they lost the adult tooth, dentistry today can give the patient a root replacement for that lost tooth or multiple teeth. But we now have the ability with sound surgical principles and with good host bone to start with, and the ability to measure that bone, to evaluate the strength of that bone, to decide at the time of placement of the implant whether we can give the patient some type of restoration. And there's no better service than giving the patient a complete restoration, albeit it's a temporary, it's plastic, but it's still a tooth replacement that they can walk out of here today and they can function in a normal manner, whether it's eating, chewing, speaking, smiling, and every other way. Acrylic temp, so you can see it picked up the white piece. What you want to look for is to make sure that no acrylic gets beyond the margin of the white piece, so that means that the white piece was fully seated. And you could just leave it in here. I'm going to put it into some hot water. I'll trim it, then we'll just place it back on the tooth. And these are have some type of internal connection that some people don't even use cement. I like to use cement so that they don't loosen. And you just put a tiny little bit of cement in there and we let it heal. We let the tissue heal around the temporary, and you'll see an unbelievable development of the gingival architecture right from this moment forward, because the tissue development is just as important as everything else. So we've replaced the root, we filled the defect with bone material, so we're going to actually regenerate the bone, and in addition, we're going to now develop the tissue architecture. So if you go back to the surgical site, look how no bleeding, there's really minimal bleeding, minimal trauma, and I would anticipate the patient will have minimal postoperative complications or sequelae. Because we manipulated the bone, because I extracted a tooth that was not in the best of shape yesterday, I am going to put the patient on an antibiotic today. I don't routinely use antibiotics, but in this case, just to cover him so he doesn't get any secondary infection. Plus, we did the scraping of the bone, and we did some bone grafting. We're going to put him on an antibiotic. We'll give him a painkiller, an option with some Tylenol 3. I doubt if he'll use them. Most patients will just use some NSAIDs, Advil, Motrin, whatever it is that they prefer, and that's usually sufficient. This is the Osteopulse by Biolux, and this is the device that's going to generate light therapy to promote healing of the new bone around the dental implant. And we are going to give this to the patient to take home, and the patient will have to wear this at home for 20 minutes once a day. And it has been developed to take advantage of a long-researched phenomena that advocates the effect of light, red light or near-infrared light, to have a positive effect on the cellular activity, actually on a certain component of the mitochondria, to produce enzymes that will promote cellular healing. And what the patient will do is, this is the control. We're going to plug this in like this, and it will tell you when you turn it on. So you turn on the device, and it'll tell you to plug in the receptacle into number 1. So I'm going to write the prescription now. And once I write the prescription, it will be set. So it says for 21 days. And I'm going to save that. You just push this button, and then you push this arrow. We plug this in and press this to start. And this red light will stay on to the surgical site for 20 minutes for 21 days. And as I said, we will get the patient back in day 10, day 14, and day 21. And we will use the same little smart peg that we had used before. We will remove the temporary component. We'll put the smart peg in, and we'll re-measure the ICQ reading. And we will see a gradual progression of a higher reading. The higher the ICQ reading, the more stable the implant is. And it gives us the ability now to augment what I know from the surgical procedure, which was where I did the torque challenge, which gave me already a significant high torque challenge reading, but this now will tell me the reading of the ICQ during the healing stage. And one of the things that we know about the healing around dental implants is that from week 2 to week 3, there's actually a little bit of a negative rebound where the bone actually weakens. And that's the time when we don't want to manipulate anything on the dental implant, because we're always worried that we could tip the scales in the favor of the weaker cells, or the osteoclasts, which are the bone-destroying cells, as opposed to the osteoblasts, which are the bone-forming cells. But with this light therapy, we are now confident that the patient will be able to have an uneventful healing and actually a more rapidly healing around the dental implant. And histologically, the bone cells that form, the new bone cells, and his own cellular activity will be promoted to work that much faster. So again, the protocol for the patient is very easy. He's just going to do this for 20 minutes every day, and that's it. And then he'll bring it back to me, and we'll be able to use this again for another patient. So I'm just going to disconnect this. That pauses it, and it actually tells you that we use like 2 minutes and 20 seconds. So when he uses it later today, he'll just finish up this cycle, and that's it. And then he'll use it again the next day. The patients can't cheat, because when he comes back, if he misses a day, it'll come back and it'll tell me 2 sessions or so were missed. So, and it won't work if the patient doesn't wear it. So if I take this off the patient, and if I try and start it, it tells me that the headset's not being worn. Please ensure it is correctly positioned. So it won't work. So it tells you. So the patient can't just push the button and leave it on the table. They actually have to wear it for it to work. So we're just going to disconnect this. As you can see, it's the acrylic is fused to the white piece that's going to go onto the post that's in the mouth. I'm going to just take some temporary cement. You can use any temporary cement you want. I happen to use this material, which is Cling. I buy it from Clinical Research. I'm just going to squirt a little bit into the hole, which is like that. And we're going to go to the mouth. Just very delicately cleaning off the cement. And what I want to do is get one picture to show you already how the tissue is thickening, or we've sutured it, and the thick tissue around the neck of the implant, because the neck of the implant is narrower in diameter than the body, there's more volume for tissue development, and you're going to see already a beautiful scaffold for tissue development. So you can see what I'm referring to in that there's room, a lot of room at the apical area of the crown towards the implant to build the acrylic out to help develop the tissue architecture. And in terms of post-operative instructions, as I said, we're going to put this patient on an antibiotic only as a preventative measure. There's nothing infectious there. We're going to give him some Tylenol with codeine in case he needs it. We gave him a couple of Advil. Probably Advil will be enough to keep him comfortable. And post-operatively, I'm going to give him a bottle of antiseptic rinse. I've gotten away from using the chlorhexidine rinses only because they have an unfortunate staining capacity, and patients would get very frustrated with the brown stain that would develop. They are, or have been in the past, the gold standard, but I've luckily discovered this product called the Natural Dentist. It comes from the United States, and it comes from actually a company in New Jersey called Natural Dentist. And a double-blind study was done at NYU under the auspices of Dennis Tarnow, where it showed no difference in the healing when patients would use this post-operatively as compared to chlorhexidine rinse. So I've been using this now for about 5-6 years, and it tastes much better than chlorhexidine rinse. It also is a product that doesn't leave any stain or any residue. And all we have the patients do is take a little bit of this. I give the patients also a very soft toothbrush. This is a post-operative brush. This is from Butler. And it has bristles that are analogous to a baby's bristle brush. And what they do is they just take a little bit of the rinse in the cap, they put it on the brush, and they can just very gently massage the area. If the brush is too sore, then we tell the patients to use a cotton Q-tip or even just a cotton ball. But we want to just keep the sutures lubricated 3 times a day with the rinse, and we want the rinse to just soak in around the neck of the tooth or the neck of the temporary to keep it comfortable. I also want to emphasize that the temporary tooth is in very, very light occlusion. There's no need to build this tooth up into occlusion because he's got his other teeth, and he's been without this tooth for so long anyways. This is really, the temporary here is, because it's a single tooth, is really needed or meant for tissue development, soft tissue architecture development, more so than the occlusion. If a patient is missing multiple teeth, then we'd have no choice. We do put them into occlusion, but then we're splinting them. And by splinting all the temporary teeth together, you're distributing the forces along the whole arch, and you're creating a greater surface area of force distribution. But because it's only one implant, to safeguard that he doesn't overload the implant and rock it out, we keep it in very light occlusion or even minimal occlusion. I've been asked by one dentist that before they start placing implants, what type of course should they be looking for and what type of cases should they be starting with? Well, obviously, there's a lot of education available today with respect to dental implants. And I think that it's important to get involved with a program which will teach one the basic skills, obviously the technical skills of placing an implant, which is not very difficult, but it's also must include the basic surgical skills, the principles involved in doing any surgery. And as well, the course should be comprehensive enough that should include some restorative componentry so that the dentist will actually know what to do with the implant. It's not enough just to place it, but you have to know how to restore it. And one thing that we teach when we are teaching dental implants is that it's the restoration that drives the surgery. So the technical skill training for placing an implant is really, really only a small part of the equation. But the real area that one has to focus on is the treatment planning and the case planning and then case management. So you must have that as part of any course. I would not, as an entry-level course, be worried about the bone grafting procedures, the sinus lifts and the ridge augmentations and all that, because that's way, way too complex and too much to absorb at the beginning. So really I would focus on a very basic course that would include the training or the skill development in placing an implant, but as well the treatment planning, case management, and restorative componentry. Another question I've been asked is what type of cement is best used for cementation of implants? I want to just clarify that we never cement implants. We always will make sure that any component that goes into the dental implant will be screw retained, whether it's an abutment or a crown. We want to make sure that that screw access hole is retrievable and accessible if the implant is ever needed for future use for any other applications. When we're talking about